I'm Dr. Pason Phonphok from Press Hospital. Today is my pleasure and it's my honor to be right over here. My topic to present is Remnant Preservation ACL Reconstruction. So every injury of the ACL or the remnant are not the same. We can see this both cases are the patient with torn ACL. On the left side, we can see that the remnant was completely detached from the footprint. On the right side, we can see the remnant, some fibers still function. So all of the ACL injury, the remnant are not the same. The ACL remnant is well-vascularized synovial sheath with numerous fibroblasts, myofibroblasts, and mechanoreceptor. If we can able to preserve the remnant of the ACL, the healing of the graft should be much more better from better synovial coverage and revascularization, and lead us to improve in mechanical properties of the graft, improve in mechanical stability, healing of the graft, and knee function. Normally, 4 weeks after the reconstruction of the ACL, the blood supply from subpelvic fat pad and synovial tissue will run cover the graft and will promote revascularization and make the graft heal and survive. Dr. Crane described 4 types of remnant ACL after injury. Type 1 is remnant that's scarring to the PCL. Type 2, heal to the roof. Type 3, heal to the lateral wall. And type 4 is remnant resorption. The remnant itself has its own stability. Dr. Crane made a notch debridement and remnant removal, and he found that it will be more anterior knee laxity in the type that the remnant attached to someone else, such as PCL, lateral wall, and roof, but there's no significant difference in anterior laxity in the group that remnant was resorbed. Dr. Kondo made a comparative treatment for the patient that he removed the remnant and preserved the remnant. And he found that if we can able to cover the remnant more than 50%, it will be more anterior knee stability. But if the remnant was less than 49%, it will be no significant difference. For about the pivot chip laxity, in this both group, it was no significant difference between both group. So the graft coverage with remnant tissue can't able to predict the post-operative rotational stability, just only for the anterior knee stability. What is the base time for surgery? All of us know that one of the key factors for graft healing is surgical timing. If we more prolong or delay the time to surgery, the number of the mechanoreceptor at the stump will decrease over time. The gene expression pattern at the stump will change from healing to fibering. Dr. Cohen made a biological study about the response after the ACL injury. He made a histological immunohistochemical analysis and found that the number of mRNA expression gene at the remnant will decrease over time. The highest number of the gene expression at the remnant is in the period of acute injury, less than 3 months. And he concluded that the ideal time for surgery should be in between 4 to 6 weeks after injury, and because of the greatest healing potential and the greatest reinnervation and revascularization of the graft. In terms of revascularization, normally the blood supply will lead us to promote revascularization of the graft, make the graft heal and survive, make more synovial coverage. One of the base evidence to prove the healing of the graft is to do second look arthroscopic finding. And from many previous studies before, they all concluded that the graft will be more thicker and better synovial coverage if we can able to preserve the remnant, but not that much in Crane type 3 and type 4. And all concluded that if we can able to preserve the remnant, it will be more improvement in post-operative graft maturation, more than the group that can't able to preserve the remnant. For about the remnant amount, some study don't agree with the outcome that I have mentioned before. They reported that the remnant volume was weakly correlated with the post-operative outcome. But by the way, one of the explanation why the amount of remnant can make the knee more stable maybe come from the amount of more amount of remnant, it will be more coverage of the tibial tunnel, and it will lead us to be less infiltration of the synovial fluid to the tunnel, make the tunnel widening more better, and the knee will be more stable. By the way, many previous study has report more incidents of cyclops lesion and extension loss if we preserve more amount of remnant. So the cyclops lesion is a fibrovascular tissue nodule in front of the graft, make more extension deficit if we do a lot like a double bundle remnant preserve ACL reconstruction. But if we do less than that, just only selective bundle ACL augmentation with remnant preservation technique, the incidence of the cyclops lesion will be less. The incidence and occurrence of the post-operative range of motion between the group that preserve and non-preserve the ACL remnant are a significant difference between both groups in terms of incidence and occurrence of range of motion. Because sometimes the cyclops lesion just only come from the stump. The cyclops lesion can able to be stimulated by drilling and preparing of the tunnel, and removing of the remnant cause more bleeding and can lead us to have more scar tissue, and the cyclops lesion can occur. So, but in terms of cyclops lesion itself, not just only come from the stump. I'm going back to the bone tunnel enlargement. Normally, there are many pro-inflammatory cytokines in the knee joint. The synovial fluids contain TNF-alpha, IL-1 beta, IL-6. The remnant can produce periostin and IL-6. So if we make more removal of the remnant, it can cause more inflammation of the knee. That's why we should preserve as much as we can for the remnant, because it will be more stable of the knee. But if we preserve more remnant, it can lead us to make the tunnel malposition. So we have to make sure that the first priority of the ACL reconstruction is the tunnel position. Don't make the remnant make us miss tunnel position. And there are many factors that can cause tibial tunnel enlargement, not just only from the stump. For the outcome, from many previous meta-analysis study, they all reported that the group that we can preserve the remnant, it will be more stable of the knee, especially for the anterior knee stability, Lichholm score. It can able to preserve more proprioception function and accelerated the healing of the graft. By the way, it depends on the morphological remnant condition and amount of remnant that we can preserve. From the study that compare the outcome between the group that we preserve and remove the remnant, it will be more better in knee stability in the group that we can able to preserve it. But in this both group, it will be no significant difference between healing status and overall complication. In the preserved group, there are no relationship between objective measurement result and patient subjective feeling. And this both group, there is no significant difference in terms of clinical outcome and knee stability when we measure by using IKDC score, Lockman test, and pivot shift test. So I'm going back to this both two cases. Should we reconstruct this both knee in the same technique? Maybe on the right side, the remnant is still quite good. Remnant preserve may be the good option for it, because there will be more advantage in to restore the joint function, stability, proprioception, and better subjective feeling. But in this both group, there's no significant in terms of outcome, rotational stability, and total complication. So I think for today, it's based on the preference of the surgeon. Nothing is the base technique to perform, and nothing is the bad or the worst thing to do. Thank you.